Okay guys, we're going to be talking about lumbar stabilization. So the most important thing is you have to always start in neutral spine. So neutral spine is the natural lumbar lordosis that we are supposed to have in our spine. It's not a flat back, it's not an excessively lordotic back, it's our natural curve. And then we have to teach the patient how to maintain it. How they maintain it is by purposefully, it's a hard word, contracting transverse abdominis. Now we're looking at our deep lumbar stabilizers. That's TA, rotatories, multifidus. If I asked you right now, contract rotatories and multifidus, you can't because they are segmental. But the really cool thing is if you activate TA, multifidi and rotatories contract at the same time, okay? We're kind of hardwired to co-contract, okay? So let's talk about finding neutral spine. I find it a little bit easier to find neutral spine in sitting because you can really see what the patient's doing, and a great place to do that is on the ball, okay? So I don't want to excessively arch if they're not supposed to. So let's think about a stenotic patient. I'm gonna have you do this from the side. So a stenotic patient, I still wanna think about that extension bias. A spondylolisthesis patient who is not supposed to excessively extend, but they can do just a tiny bit just to get the feel, and then they can slump. Now my disc patient, maybe I don't want them to slump a whole bunch. Again, we just got that disc material reduced. We don't want to throw it back out. So be cautious, think about your biases that we talked about. But basically, if you tell your patient, arch your back as much as is comfortable, there should be no pain, slump your back, and just kind of work your way back and forth between those. And if you're in pain, you should feel a spot that feels the best. Or if you're not in pain, that's great. You should feel a spot where you just feel like you're in really good alignment, okay? You help the patient find that, okay? You're gonna get really good at being able to eyeball it and make suggestions like, oh, a little bit more extension, a little bit more flexion, whatever, okay? It's just a little bit easier for them to mobilize and get the feel for it in sitting. But the first position we're gonna have our patient do is either supine or prone because the table is gonna give them so much support. Okay, so again, if I had my patient in supine and they kind of got lazy or let it go, they certainly might flex. Okay, so here, this is a flexion bias. It's gonna put my patient into flexion if they're not careful, okay? So this would not be good for a disc patient, but it would be good for a stenosis patient, okay? If they had spondylolisthesis, this would be good because they're not allowed to extend, remember? So again, that's the bias. I can get rid of this. So first thing you're gonna ask your patient to do is find neutral spine, and they can arch and contract. And they're, oh, feels good right about there. And you say, great, now contract TA. And they say, what's that? Okay. Easiest place for you to feel TA is find the ASIS and go just medial to it and press down, and then tell the patient, suck in your tummy, hey, and you feel a tightening. And you go, yay, I found it. Okay, now don't let it go. And a lot of patients will go, okay, and they hold their breath, and that's not good. Okay, and when they do that, they arch their back. Okay, so this can take a while to teach them how to contract TA. It's much easier with the knees bent. Here, you're going to go into extension, and it's harder to find neutral spine. So a nice hook line position. Once they've found neutral spine, they activate TA. You see if they can hold it. 30 seconds. Once they can hold it 30 seconds, you start with the motion progression. So you would start one arm, And again, this is all about endurance. So usually you do it for 30 seconds. If they're moving fast, you're gonna see lots of excessive movement. Sometimes when people get back here, they arch, okay? So some modifications might be telling the patient to slow down, or modifications might be, you know what, just stop right there. Don't go back over your head, okay? Once they can do one arm, you ask them to do the other arm. Once they can do that, they would alternate arms. Once they can do that, it would be a double arm. Once they can do their arms, you go to the legs, and you would have them do one leg. And again, you may not go all the way up here, and you're not going to go all the way to the chest because you want to keep that neutral spine. You're always checking TA. Okay, once they can do one leg, do the other leg. It's very common to find that it's easier to move one leg than the other, or move one arm than the other. So a patient might have to practice more on one side of their body than the other, okay? You would go to alternating. They can have their arms down. I'm just moving my arms so you can see. And then they can absolutely do two legs, okay? You can make it really hard and have them do long lever arm, okay? Oh, I forgot, dead bug. Once they can do both legs, then you have them do legs and arms together, okay? Now, from here, I got it correctly, you might have the patient go into sitting or quadruped. Okay, remember I had them supine. That meant that we don't like extension. I'm sorry, let me say that again. That means we don't like flexion, extension. Wait, I was supine. Okay, don't mind me. Flexion is okay in supine. So we would go to sitting, okay? Because in quadruped, if somebody got lazy, when is this going to be over? This is so tiring. Look what happens. They're going to go into excessive lumbar lordosis, okay? In sitting, if somebody gets tired, they go, okay? That would be excessive flexion. So thinking about which one's okay for your patient, okay? So again, if I have a stenosis patient, spondylolisthesis patient, I might be more prone to starting in supine and then going seated, okay? I'm gonna be sideways, okay? Higher developmental position, but you start with the same thing. You find neutral spine, activate TA. You can certainly do this on a chair, but what you'll find is if someone's not holding, you can really see it with the ball, okay? One arm, then the other arm, then alternating arms, then both arms, okay? When you get to the legs, you might start with just a heel tap or a slide, okay? Having socks on would be a little bit easier. Because I'm already in a 90-90 position, this ball is a little bit short for me, okay? It's hard to lift my knee up higher without going into a posterior pelvic tilt, okay? But if I can, cool. Okay, I can do one leg, then I can do the other leg. I can't really do both legs, but I can do each leg, and then I can do arms and legs, okay? Let me just show you what kind of the extension bias looks like. That would be in prone. You can certainly have a little towel so your patient can breathe. I can breathe okay. Okay, find neutral spine, activate TA, and you would just slide your fingers right inside, just medial to the ASIS, okay? And if they had good range of motion of their shoulder, you could have them lifting up like this. If they don't, you could just have them sliding their arm. Okay, one arm, then the other arm, then alternating arms, then both arms. Okay, then you go to one leg, the other leg, alternating legs, both legs, arm and leg. Okay, you want them to get to where they can do 30 seconds of whatever activity. So they would spend 30 seconds with one arm. If they did well with that, they would do 30 seconds with the other arm. If that's not really challenging them, then they go to 30 seconds alternating arms. Okay, I'm just trying to show you the progression. Okay, if you're going to do quadruped, it's much easier to do this up on the table, and you want knee right under hip and wrists right under shoulders. Okay, have them find neutral spine, hold it, the TA, and you might start with a march or a slide, and I just felt I lost it. You'll find this is a very challenging position. Let me get off this. Okay. And this is my hard side. I do great with my right arm. It's hard for me to do my left. Always has been, always will be. After I do each arm individually, I could go to a march, and you can see how much I really have to set and concentrate before I lift up my, my left arm. For legs, it's easiest if your feet are hanging off the table, because if I'm here, I'm sliding and I'm having to deal with my foot. If I'm here, it's so much easier for me just to slide this way, and my foot doesn't really get in the way. And I'm sure you guys have seen the pièce de résistance, which is this wonderful thing. It's all about the core. You can certainly use it for scapular stability, but your target tissue with that is really the core. Okay? These are all early lumbar stay. Okay? The earliest lumbar stay would be supine and prone. Kind of middle of the road would be quadruped and seated. Late stage lumbar stay is going to be function. Okay? So, can they hold neutral spine and pick things up and put things away and lift things overhead? Can they, had to see where this was, can they hold neutral spine and go up and down stairs? Okay. Can they hold neutral spine and do a floor transfer? Okay. Can they do neutral spine and vacuum? Can they hold neutral spine and do anything? Okay, picking up children, household chores. If you want to get into sports, that gets a little bit tricky. Okay, but late stage is always going to be functional activities. Okay, think of anything functional, and now ask your patient to find neutral spine, activate their TA, and have them do it. Okay, those are the basics.